Hello and welcome to JAMA Health Forum Conversations. I'm Dr. Sandro Galea. I serve as Dean of the School of Public Health at Washington University in St. Louis. I also serve as Editor-in-Chief of JAMA Health Forum, a peer-reviewed open-access online journal focused on health policy, healthcare systems, and population health, one of 12 specialty journals in the JAMA network. We are living in a time of intersecting challenges. The U.S. healthcare system is both a driver of innovation and a generator of prohibitive costs for millions of Americans. Immigration remains a source of America's strength and richness, but it has strained our politics as cruel policies become increasingly the norm. Global trends like urbanization are reshaping how we live. We are still reckoning with the costs of COVID in lives, health, and economic after-effects. The 2024 election brought to power an administration that has disrupted much, creating a new uncertainty for health and the structures that support it. Untangling these challenges calls on us to exercise clear thinking and a willingness to engage with complexity. It means being able to see the present with an eye towards the future, to understand what is happening now and may be coming next. I'm very pleased to be joined today by someone who is very good at doing all of this. David Cutler is the Otto Eckstein Professor of Applied Economics at Harvard University. He holds secondary appointments at the Kennedy School of Government and the Harvard T.H. Chan School of Public Health. He advised presidential campaigns of Bill Bradley and John Kerry and was senior healthcare advisor for the Obama campaign. He also served on President Clinton's Council of Economic Advisors and the National Economic Council. He is author of several books, including Your Money or Your Life, Strong Medicine for America's Healthcare System, and Survival of the City, Living and Thriving in an Age of Isolation, which he wrote with Edward Glaser. I'm delighted that David's here with us for a conversation about the forces shaping health in this moment. David, welcome.
Thank you. It's great to be with you.
So let's start with the present moment. The Trump administration has taken a range of consequential actions over the last few months. What, in your view, are the most significant of these actions for the health of populations?
You're right. They have taken a wide range of actions. I'll highlight two that I think are particularly important. The first one is not something we think of as conventional health policy, but it's immigration policy. A lot of the healthcare workforce is immigrant labor. It's relatively low skilled. Think about people who are working as personal care aides, home health aides, technicians in various forms. And the policies around immigration can have a very real impact there. So one of the things that I'm worried about is that, for example, people who are frail, who need support to live independently at home, will find that support increasingly unable to be found, or the price will go up, or it'll have other restrictions on it. And I think that could be a really severe consequence for people who really need that help to get by on their own, as well as for their families, particularly children, particularly female children, some of whom might have to drop out of the labor force to care for them. So that's the first one. The second area that I'm really worried about is the impact of cutting the biomedical research activity. So the Trump administration's budget proposes a 43% cut in the NIH spending, also cuts in NSF and slowdowns in FDA because of cutting people there. One of the drivers of health improvements over time has been new medical innovation, particularly pharmaceuticals, but also other areas. And I'm worried that will really slow down a lot with the cutbacks. And in fact, if you look historically, the impacts of spending less could be really quite catastrophic for the nation's health.
David, let's talk about the first one, the immigration policy. So are there policies and approaches that actually can mitigate some of the negative effects of the immigration actions right now on health?
Yeah, so if you think about the need for workers in health, so we have several programs that have tried to deal with the existing needs. One of the hardest things that we've had in the US has been difficulty attracting people outside of major urban centers. We have in the Massachusetts area quite a lot of doctors in the Boston area, but in more rural parts of Western Massachusetts, it's hard to get doctors. Same thing with rural areas throughout the Midwest and the South and the Mountain West and so on. We have had various programs over time that bring in foreign doctors into underserved areas, that reward people with loan forgiveness if they work for a number of years in an underserved area. Those have traditionally been at the doctor end, occasionally at the nurse end, but we may want to think about those in other areas of healthcare too, where we're likely to see shortages. Again, particularly in things like home health aides and personal care aides, and other areas where if we don't invest in them, the consequences for the individuals could be very big, as well as the consequences for their families who will now have to care for them when there's no other way of doing so. So I think we'll probably have to look into targeted immigration carve-outs for people providing important healthcare services, especially in areas where we've lost a lot of that labor.
And since we're talking about mitigation, how about the second threat that you mentioned, which is the threat to the biomedical research establishment? How can one mitigate that?
That is also something that we're going to have to think about. Congress is going to have a lot to say about that. For example, what happens in the president's budget when he's proposed a big reduction in NIH spending and other kinds of spending. There, to me, the issue is money, which is if you're going to take money out, you're going to have adverse consequences. If you're going to put money in, you can have better consequences. That's not to say that all money is good and taking every dollar out is bad, because we know there's waste in every system that we look at. But I really think the big issue there is going to be, what does Congress agree to go along with? To me, it would be incredibly foolish and extremely short-sighted to say, let's take $20 billion out of the budget, which is rounding error on the government budget. And as a result, some large share of clinical trials stop and labs close and mouse colonies, cell colonies get shut down. Unfortunately, biomedical research is something that you can't just turn the switch off and on. Once you turn the switch off, it takes a lot of years to rebuild it. And I'm worried that what's happening now is turning the switch off, and then you can't just turn it on as readily in the future.
Yeah. Let me go back a little bit now, David. Let's go back to 2020. So you and Larry Summers wrote a viewpoint in JAMA Health Forum about the costs of the COVID pandemic. So now we're 5 years later. Can you reflect back a little bit on the economic effect on COVID, and how do you think what happened aligned with your forecasts, and how other factors that have emerged since, including burden of long COVID, how are they going to shape the long-term economic legacy of the pandemic era?
Looking back is always a great time for reflection about this. When Larry and I wrote it, we got some things right and we got some things wrong. On the whole, I think we did okay in that the economic shocks of COVID were quite big. The fact that a lot of people were not at work was really a huge economic shock. Fortunately, the U.S., we were able to borrow on it, but that raised the debt of the U.S. a lot. That's now problematic as interest rates are going up for various reasons of the administration and the global economy and so on. So that could turn out to be a really big shock. The biggest economic shocks were in the way of health degradation from the pandemic itself. The administration, Trump administration at the time, actually did a wonderful job with Operation Warp Speed and things like that. So that was actually a very terrific thing that happened. I wish we would see more of that going forward now. The biggest residual item is, so we think, oh, COVID is over and so on. Long COVID is still a very severe issue for a lot of people. Fortunately, it's not as bad as some of the forecasts had suggested it would be, but that doesn't mean it was not bad at all. And there's still a lot of people who are suffering from the consequences of long COVID, some formal through medical care, so people who still have brain fog and cardiac issues and respiratory issues and so on. And then some just because being outside of normal events for a while really hurt things, like many kids lost ground who were not in school, who could have benefited from being in school. That's not a medical event, but that's another long-term consequence. So the economic legacy is huge. One of the things that I'm disappointed by, to come to the earlier question about the administration, one of the things I'm disappointed by is that, amongst other things, they seem to be cutting the budget for pandemic preparedness, and certainly doing less with the World Health Organization as well. Right now is the time where we should be leaning into trying to prevent the next pandemic, not leaning away from that through short-term budget cuts or because we don't like the way one particular institution operates or anything like that.
If memory serves, in that paper with Larry Summers, you estimated 16 trillion economic cost to COVID, which is roughly the same as GDP of China. Have there been more recent updates on that?
I haven't seen any official updates, and I haven't done them myself, although I think it is something that one should do. I would guess that would be about right, given what the health consequences turned out to be, which were reasonably predictable at the time. And then there was also, of course, the loss of GDP, which again was concentrated early on. So my guess is that would be about right, but I haven't seen someone go back and do a retrospective.
Let's shift a little bit. Let's shift a little bit to the ACA. So you were one of the intellectual architects of the Obama administration's health policies. Talk to us a little bit about the current status of the ACA your concern about the ACA's vulnerabilities or not at the moment, and how we can strengthen or improve the ACA in coming years?
So the ACA has, over the past 15 or so years since it was enacted, really become a central part of the healthcare system. For the first decade, there were constant threats that it would be repealed. It came to a head early in the first Trump administration when Congress chose not to repeal it. Since then, there's been very little groundswell about repealing the ACA. So it's become a central feature of the healthcare system. It's really had an enormous impact on people's health insurance coverage. It's had an enormous impact on the financial viability of various kinds of providers. So it hasn't done everything it was supposed to, but it's really been, I think, a big improvement in the healthcare system. What we're seeing now is this sort of tension about how much can we afford to do and do we cut back? Typically, the cutbacks now that are being contemplated are less in the nature of the ACA cuts and more in the nature of just cutting Medicaid as a whole. In the administration's budget, it proposes that when Congress is trying to pass a budget, the money that they want to use for a lot of the tax cuts would come from unspecified as yet Medicaid cuts. So it's interesting that it's not the ACA that's being cut, it's Medicaid. To some extent, though, it's the same sort of thing, which is those are really critical health programs for low to middle income people. And I think there's going to be a real fight over the next couple of months and years about where are we with respect to our commitment to low and middle income people and their health care. And I don't see strengthening the ACA as being on the agenda. I think what's on the agenda at the moment is defending programs or cutting them, depending on whether you see it as a necessary thing to cut them or as a necessary thing to defend them. That's going to be a huge storyline for the next bit is, are the programs cut in a material way? And if so, what does that mean for people?
So you wrote a piece in JAMA Health Forum, I really like this piece, called Financial Games in Healthcare, Doing Well Without Doing Good. And it's about how healthcare players can manipulate the system for profit at the expense of care quality. Talk us through a little bit. Talk us through some of these financial games. How do they work? And what steps should be taken if one is serious about reforming the health system to ensure that those with a financial stake in healthcare can really do well and actually do good at the same time?
So as you said in the question, what we want for people to do well by doing good. And unfortunately, in healthcare, there are a lot of ways to do well that don't involve doing good. It has to do with the sort of complicated nature of healthcare payments, but here are just a couple of examples. Most insurers or most groups, like governments running insurance pools, pay more for people who are sicker than people who are healthier. Okay, so that makes a lot of sense, right? You need to pay more to doctors to care for sick people than healthy people, and you need to pay more to insurers that enroll sick people than healthy people. But that means there's enormous incentive for providers and insurers to make it look like everyone is on death's door. Because the sicker that people are, the more you get reimbursed. So people spend a lot of money trying to make people look sick. Not caring for them better, which would be fine, but just documenting everything and then taking that documentation, turning it into money. So we have an enormous share of employment in healthcare, which is not devoted to making people better. It's devoted to documenting things so that people get paid more. Or another example is we have a number of firms, typically they're private equity, although they don't have to be, that come in and say, we'll buy a hospital, we'll give money up front, and then we expect to be paid back over time. We'll take the assets and we'll sell the assets. And then we'll take that money and we'll use it to pay ourselves. Now, then if the thing works out, that's great. We'll repay the loans. If not, we'll go to the state or local government and say, if you don't give us more money, we're going to close the hospital. And sometimes you just go ahead and close the hospital anyways. So you've taken money out of the system and then you've left taxpayers and sick people to pay the bills. Well, that's not very sensible policy, right? It's one thing if one of the 7 department stores closes, but it's another thing if the entire community's access to acute care closes. There are things in the private sector that make a lot of money, selling assets, taking the proceeds, giving the debt to someone else that if they can't repay it goes under. That may be fine as a private deal, but that's not great as a social deal. And so those are things that unfortunately are becoming increasingly common, all of those things, all the billing games, all the games in terms of asset sales and leasebacks and so on. Those are all things that I think we're going to have to police because healthcare is too important to just leave it to unscrupulous folks, if you will. For some industries, that's okay because when one fails, another firm comes in, but that's not the case with your local hospital. That's not the case with the local emergency department. That's not the case with your local doctor and so on. So I think we're going to have to be much firmer in laying down the ground rules before we let just unfettered access to businesses investing in healthcare to go on.
One can't help but feel like there is an enormous amount that one can do to improve the health system if one were serious about improving the health system. It is a hope in the current moment of turbulence that there is a genuine commitment to doing that, in which case there are some of these prescriptions, which I think you've laid out quite nicely in your papers. Let me just shift a little bit to linking things in the academic literature to actually to the real world. You've done translation, so to speak, meaning linking science into policy at the highest level. Talk us through that. Talk us through the gap between science, scholarship, and policy, and how we can more effectively perhaps bridge that gap.
It's a very tricky situation because we want to do good policy. And if we knew, of course, what the right policy was, we would have done it already. So most of the time we're dealing with policy issues, it's because we really don't know the right answer. And I have a lot of sympathy for policymakers on all sides of issues because many of times they're really trying to solve a problem and we don't know how to do it because we just don't have experience with solving that problem yet. So it's very hard to say exactly what to do. So a couple of things. One is when we do things, we should always try to learn from them, both successes and failures. So when we try something like the Affordable Care Act, we shouldn't be afraid to then go evaluate it and say, did it work? Which parts worked and which parts didn't work? And the things that didn't work, we shouldn't be afraid to try something different because that may be the best way to do it. So in part, we want to think about being scientific about what we do. I think in part also, when I approach a policy issue, I try not to think, oh, I clearly have the right answer and my answer must be the right way. Because I don't feel like I have the right answer. I often have principles in my mind. So what I try and do is I say, what are my principles about what we should be trying to do here? And then say, now, in light of that, let's talk about what to do. And maybe something that I think wouldn't be that successful, we do it and turns out to be quite successful. And maybe something I thought would be great turns out not to be so great. But the key is if you know where you want to go, it's then easier to do the corrections that are inevitably going to happen along the way. Underneath the cover of a ton of partisan fighting, there are some areas of healthcare where there is a lot of agreement about where we ought to go. Pharmaceutical pricing. Pharmaceutical prices in the US are too high for a lot of people relative to what they can afford. Administrative costs in healthcare. The overall cost and use of healthcare in the US relative to other countries. So there's some areas where there is general agreement where I hope we can make progress even as we're going to fight bitterly over other areas.
I like that hope. It is an actionable optimism, which I like. Let me ask one last question. This is a different topic, but it's about your book, Survival of the City, which I really like. Your book talks about the future of cities. Talk us through some of the challenges for cities in the moment and in the future. And talk us in particular about how cities reflect inequities that drive health divides and the kind of vision that's going to be required to make sure everybody in cities can flourish in decades to come.
So this is, I think, a huge issue. And of course, COVID brought it to the forefront, but so did so many other things. Cities are where we go when we don't want to have distance between ourselves and other people, right? Cities are like what happens when you bring people together. That's always been great because people are social animals and they like to be around other folks. People are happier in cities, so people who live in big cities are happier than people who live in rural areas. People earn more in cities. The same person doing the same job earns more in a bigger city than in a smaller city or a rural area. So all of that's great, but cities are also areas where disease spreads. And in fact, for most of human history, cities were less healthy than rural areas, and it was a real struggle between I want the opportunity of a city, and therefore I'm going to go there, versus I understand that I'm less healthy as a result. It hasn't been till the past 100 years or so that cities actually became healthier than rural areas. What pandemics do is they tip that balance back again to where we were. So, of course, COVID was worse in cities than in rural areas. Bigger cities around the world and so on are where COVID spreads easiest. We're going to have to think about health policy as being not just national policy, not just being international policy, but local policy as well. By which I mean the following. Let's say you're in New York City and you live in Manhattan. Certain zip codes in Manhattan are among the richest in the country and people have very long life expectancy and so on. And about 10 miles away in parts of the Bronx are some areas with very low life expectancy. And you can literally go 10 miles and lose 10 years of life expectancy for living there. And people in Brownsville, which is a low-income part of the Bronx, have lots of health conditions that are associated with spread of disease, obesity, and respiratory issues, and drug use is more common, and so on and so forth. And you say, well, okay, I'm in the rich part of Manhattan, so maybe I don't need to worry about that. But actually, one is never that far away from people who have risk factors for disease. A subway ride and a bus ride and a Starbucks interaction, and one is interacted with someone who's interacted with someone who lives in Brownsville, which means that I think no person anywhere can really be totally safe if we don't think about all of us. That is, the health of people throughout New York is going to be driven by how New York, city and state and the federal government and so on, respond to health crises in areas like Brownsville. And that's a different way of conceptualizing it, because we've often thought about there's national policy, and local policy doesn't really think about health in quite the same way, but it really has to, because really the only way we're going to all be safe is if we watch out for each other. And we say, actually, shared needle use is a problem because it's a problem for everyone, even those who are not sharing needles. And respiratory issues can become a problem for everyone. And so that's going to have to be on the public agenda for people to feel comfortable living around others.
David, your message of constructive optimism might just carry us through the moment. I'm Sandro Galea. I'm here talking to David Cutler. We've been talking about the intersecting challenges of the moment. You can find a link to articles by David and by myself on these topics in the episode's description. David, thank you for joining us.
Thank you. It's been my pleasure.
This episode was produced by Shelley Steffens at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com, jamahealthforum.com, or search for JAMA Network wherever you get your podcasts. Thank you, everyone, for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.